as well as treatment. And maybe double crash syndrome, we may not look at much, but double crash syndrome is also something I would want you to have a look at. This is in your level 4, isn't it?
Yes, yes, Doc.
Many of these things tend to come up in level 6, so also check up on what double crash syndrome is. As a definition, nerve entrapment syndrome is a pressure-induced injury. Okay, pressure-induced injury to a segment of a peripheral nerve secondary to anatomical or pathological structures. So what is happening is that a nerve encounters pressure, a peripheral nerve, and it may be due to disturbance in anatomy, or maybe like in carpal tunnel syndrome on the wrist, there is due to body swelling. Sometimes in pregnancy, the ladies may present with carpal tunnel because of edema. The anatomical structures have swelled, okay? Or due to even a fracture of the wrist can cause carpal tunnel syndrome because of a fracture which has reduced the size of the carpal tunnel. What are the mechanisms of injury in nerve entrapment syndromes? They include: 1, chronic direct compression, which may be external or internal. When you talk of chronic direct compression, in case of internal, maybe say due to a fracture in the wrist. So a fracture in the wrist or the distal radius, and that result in hematoma formation, or even the fracture itself may compress the median nerve in the wrist and cause carpal tunnel syndrome. And external pressure may also cause the nerve injury. Angulations in different parts of the body where nerve makes sharp turns, that may also trigger nerve entrapment syndrome. Thirdly, stretching forces causing mechanical damage to the nerve can also contribute to injury mechanism. Now, another way of looking at the injury mechanism is in what situation is the anatomy really, the anatomy of causation of the nerve entrapment syndrome. It may occur in a fibro-osseous tunnel, fibrotendinous arcade, or abdominal bands causing compression. For example, in the fibro-osseous tunnel, a good example is in the carpal tunnel or tarsal tunnel or suprascapular nerve tunnel. When you talk about fibro-osseous tunnel, for example, in the wrist, I'll refer commonly to carpal tunnel syndrome since it's common, the most common nerve entrapment syndrome. So the carpal tunnel is formed posteriorly by the carpal bones, and anteriorly by the fibro-osseous, the retinaculum. Okay, so in there it can be compressed because on one side there are bones, the other side there is a fibrous tissue, so that it's a limited space. So even if there is any issue that causes the space to become smaller, then the median nerve that passes through that carpal tunnel will be pressed. Tarsal tunnel is found in the foot. Suprascapular nerve tunnel is in the shoulder. And the other mechanism apart from fibro-osseous tunnel is fibrotendinous arcade, like in the supinator in the elbow. Piriformis syndrome would occur in the gluteal region where the piriformis muscle is. This is in the gluteal region. Peroneal nerve entrapment will occur, of course, at the knee, where the peroneal nerve passes close to the fibular head, just below the knee. You may also have interosseous nerve entrapment in the interosseous nerves. Thirdly, the other mechanism due to anatomy would be abnormal bands causing compression, like thoracic outlet syndrome. In the thoracic outlet syndrome, it's usually in the upper part of the thorax, usually the first rib, and sometimes people are born with abnormal bands so that there's pressure on the nerves between the first rib or second rib and those bands. There's also myalgia periaesthetica, which occurs in the hip region. Now, what happens? The explanation for the nerve entrapment syndrome is that external pressure reduces flow in the vessels supplying the nerve with blood. Okay, and this causes local ischemia, and which has an immediate effect on the ability of the nerve axons to transmit action potentials. And as the compression becomes more severe over time, there is now demyelination, and that damages the axon and there's resultant scarring. So in short, the pathophysiology, number one, is due to the pressure to the entire nerve, the blood supply is interrupted, and if the pressure continues, then the nerve itself. So there's number one is the nerve, the blood vessels being disturbed. Number two is the nerve itself. This diagram shows a single nerve cell, an axon, and how pressure here will eventually result in sheath loss, disconnection, and degeneration. Okay, so you can see that here the nerve itself, the anatomy has been disrupted due to continuous long-term pressure. But remember, the first mechanism I told you was interruption of the blood supply, because nerves, within a nerve, there are many hundreds, even thousands of such axons. Okay, and of course, then there is blood supply to it. So initially, blood supply will be interrupted. Later on, we will see this mechanism whereby the nerve itself is disturbed. And I'm sure you remember Wallerian degeneration in your physiology books, and this is basically what Wallerian degeneration is all about. Where pressure on the nerve, you know that this axoplasmic flow, the cytoplasm flows the same way that nerve impulses move from that side, nerve endings towards the cell body, and then this is connected to other nerves, and it continues. So I'll give you some examples of nerve compression syndromes. Taimur, we're still together. Taimur, can you still with us? Huh?
Yes, doctor.
Thank you. Yeah, so these are examples of nerve compression syndromes. In the upper limb, I've just highlighted some. As I said, carpal tunnel syndrome is the most common. This diagram is showing you basically what happens in carpal tunnel syndrome, whereby you have on the volar or anterior surface, you have the transverse carpal ligament. Okay. Below it, you have the median nerve as well as tendons inside the carpal tunnel. Then on the posterior aspect, you have the carpal bones. Okay. So that carpal tunnel syndrome is because there is reduce in the volume of the carpal tunnel. As I said, in pregnancy, with edema that may occur, in a fracture, even a dislocation of a wrist, so that there is a reduction in that carpal tunnel, pressure on the nerve, and that pressure on the nerve will initially interrupt the blood flow to the nerve, initially interfere with the blood flow to the nerve, and then secondarily you will also get pressure on the nerve itself, taking me back to the diagram where there is Wallerian degeneration. Okay. And one is cubital tunnel syndrome, occurs in the elbow. Supraspinatus syndrome, okay, this one in the shoulder. Supraspinatus nerve, which passes upper part of the scapula. We have the anterior interosseous syndrome and posterior interosseous syndrome, which occur in the interosseous nerve in relation to ribs. Next, the interosseous is in relation to the forearm. Interosseous nerve passes in the forearm. Next, we move to the lower limb. These are examples of nerve compression syndromes in the lower limb, and this will form nice MCQs for you, whereby we'll ask you, which of the following occur nerve compression syndromes occur in the upper limb, and we can mix and match. So myalgia paresthetica, this diagram is showing how myalgia paresthetica occurs, whereby we have the lateral femoral cutaneous nerve, is the axis, the anterior superior iliac spine. It just passes below it and below the inguinal ligament. So sometimes you may get pressure on the lateral femoral cutaneous nerve, and you get numbness and normal sensations below this in this region, lateral aspect of the thigh. That is myalgia paresthetica. There's also tarsal tunnel syndrome in the foot. Piriformis syndrome, as I mentioned before, would occur in the gluteal region where the piriformis tendon is. Peroneal tunnel syndrome in the knee. Radial tunnel syndrome, where the radial nerve passes. Tarsal tunnel is a repetition. These are repetitions. This diagram again shows the piriformis muscle. Remember, the sciatic nerve passes below this, and the piriformis muscle tendon, they can put pressure on the sciatic nerve, and you get numbness and weakness sometimes below in the lower leg. Normal sensation, okay, whereby if you touch someone with a cotton wool, this is a specific sensation one feels, but if in dysesthesia, one may feel like you're being touched by something rough, okay, and yet you're using a cotton wool. Hyperalgesia means increased sensation, and someone touches one's skin lightly, but the person feels like again there's increased. It's like you're being scratched, yet you're being someone is touching with a piece of cotton, but you're feeling like you're being scratched due to increased sensation. Next is spasms. May also be another positive symptoms. And then we go to next is the negative symptoms, where we talk of and reduced conduction. Anesthesia means there is reduced sensation. And then we move to hypoesthesia, which is similar, and then weakness, whereby in severe cases, you may find that there is weakness in the upper limb or in the lower limb. Next, we move to once the patient has come complaining of the different symptoms, whether they're positive or negative, you now need to go and examine. And there are three components that you look for: motor changes, sensory changes, and also motor changes. In motor changes, there is a deformity. For example, in the carpal tunnel syndrome, you find wasting of the thenar and hypothenar muscle. So the hand, when you compare the two hands, this affected side, there is wasting. The hand looks smaller, flattening of those eminences. There may also be loss of movement in severe cases, whereby there's actually, that's like talking of paralysis, and also lagging where the movement is reduced, or it's delayed rather than reduced, because loss of movement is not there, lagging movement is slow. Next, sensory changes. There may be, of course, loss of sensation, and you know how to test for sensation using fine touch. You're using a piece of cotton. Pain, you're using a pointed object. For example, the paddle hammer has like not a needle, because now you'll be pricking, but a pointed object. Then autonomous, maybe autonomous changes. Then for vasomotor, you may find that there is pilomotor changes, whereby the hair reduces. Okay, if you compare the right and the left side, not in carpal tunnel syndrome, but say in even piriformis syndrome, whereby there's reduced hair growth. Remember that even hair growth is affected by the nervous system. So there may be reduced hair growth. Trophic changes, there is drying of the skin because there is affection of even the sweat glands. So because of sweat glands affection, they don't function normally. And remember, even the sweating is important to keep skin hydrated. So where you find that there is affection of the trophic changes, the skin becomes very dry. And you can compare the two sides and see pilomotor is with the hair, and you find that there is reduction in the hair growth. So this is what one would look for. Look where there is, you are suspecting nerve entrapment syndrome. You look for the motor changes. And this one is mainly by not only inspection for wasting, but also do movement. We'll ask the patient to move, okay, the particular area involved. The sensory changes, we say you use the cotton wool, use the pointed tip to check for fine touch and pain sensation. And then next you move to vasomotor changes, looking for the hair growth and how the skin looks like. Is it dry? Next, once you have examined the patient, there are special tests. A common one is Tinel sign. Tinel sign, if I can use diagram in Tinel sign, if, for example, if you have carpal tunnel syndrome, if you tap the region where the nerve is being pressed, you'll get numbness or even paresthesia distal to the area. So in carpal tunnel syndrome, you knock the area of the anterior to the carpal tunnel, use your finger and tap, and the patient will feel sensations going similar to what they usually feel going down the fingers. So that helps. It can be done anywhere where the nerve is relatively superficial to diagnose neuromuscular and nerve entrapment syndrome. So that's called, it's a Tinel's test. And when it's positive, you now talk of positive Tinel's sign. Apart from that, there are some specific investigations which one can ask for, basically nerve conduction tests and EMG. Nerve conduction test assesses the integrity of the sensory and motor nerves, okay? Because you have said if the nerve is being pressed, then the impulses will not flow normally, okay? So the tests are checking how you put, for example, for the nerve carpal tunnel syndrome, you'll put one electrode around the elbow, another one in the fingers, and check how the nerve impulses are passing through. If it's abnormal, then it will show you. EMG tests muscle activity, electromyography. A needle is placed in the muscle and checking for nerve denervation, so that if the muscle is affected, say by injury to the nerve or the muscle itself, then you'll find that there are abnormal waves that will appear. Apart from those specific electrodiagnostic tests, that's NCS and EMG, we can also do an MRI, okay, in the area we are interested. If it's piriformis syndrome, we can do an MRI in the pelvis, checking for where, looking for signal changes, okay, near the nerve. There are also sweat tests. As I said, we talked of the trophic changes and pilomotor changes, so that sweating usually when there's nerve entrapment, sweating is reduced. So you can check for sweating on right and left side and compare the two. And also general investigations. We're looking for diabetes. We know is a common trigger for nerve entrapment. What treatments are available? There are conservative and surgical treatments. Okay, conservative and surgical treatment. Conservative includes lifestyle modification. For example, you may find a secretary who types a lot and she's getting carpal tunnel syndrome. Then she may need to reduce or break her typing sessions into blocks so that she does not type continuously for 4 hours, but maybe take breaks in between. Splinting also helps to splint the area involved. Medications, specifically like non-steroidal anti-inflammatory drugs like Brufen, also corticosteroids, they reduce inflammation. Sometimes you may give a local injection. Even for carpal tunnel syndrome, you can give an injection directly into the carpal tunnel, and that reduces inflammation. There's a role for physiotherapy, whereby there's the specific ultrasound, not the ultrasound for diagnosing stuff, but for reducing inflammation, heat therapy, ice, among other devices. Also, sometimes patients need counseling, whereby there's a supratentorial trigger or their psychological issues that are worsening the condition. Surgical treatment involves removing the offending structure. You may have a fracture that once you correct that should resolve. You may also need to do decompression or release. For example, in the carpal tunnel syndrome, sometimes what one does is to release that transverse carpal tunnel ligament, okay, to create more space, because there's pressure. The tunnel is narrow. By releasing that, you increase the space of the tunnel, and that helps with the recovery. Next is neuroma excision, where you have maybe a nerve is partially injured and there's formed a painful neuroma. You may excise that. Sometimes the nerve gets so painful that, and maybe it's a sensory nerve, so you may want to of course, the limbs, you may want to even resect that nerve. After you try all modalities, all the conservatives are failing, then nerve resection sometimes may give relief for a patient who has severe pain, which is not resolving. Next is nerve repair, where the nerve is maybe torn, it has undergone complete degeneration. Nerve grafting can also be an option. The sural nerve, which runs in the foot, sometimes is available and can be taken. It really gives its sensation to the lateral aspect of the foot. So that nerve grafting may help. Last but not least is nerve or muscle transfer. Thank you for listening. Any question? I saw some question in the chat about radial nerve. Oh, I think I'd put radial nerve. Let me go back. I'd put radial nerve under. Who asked the question? So let me see, radial. Oh yeah, the radial, apologies. So the radial tunnel I've mentioned here, this one will actually fall under, the radial tunnel will fall under the upper limb, because the radial tunnel syndrome actually, patient feels usually pain in the forearm and in the hand, and due to pressure on the radial nerve. So that will definitely, radial nerve is in the upper limb, so that will fall in the, not too common. So the radial, not in the lower limb, but in the upper limb. Sorry for that error. Any other question on the, and as I said, you should check on the neuromuscular conditions like Duchenne muscular dystrophy, the spinal muscular atrophy, facioscapulohumeral, okay, and also revise on the nerve entrapment syndromes. Particularly these two slides would be important, the upper limb and the lower limb. Any burning question, maybe from Patel?
There's a question in the chat box, Doc.
Okay, let me see if I can get to it. How does nerve transfer work? Does it have to be same modality nerve? Yes, that is a very good question. Nerve transfer. That's a good question. So now, usually, definitely it has to be the same modality. Not a very common procedure, but it is one of those options. Okay. So that if you have next is why give psychological support to these patients? We understand that there is usually a connection between, for example, if there's a connection between, the nervous system, the autonomic nervous system, central nervous system, so that even in cases of depression, someone who has been having pain, say knee pain, back pain, when that is worsened with, or even the nerve entrapment syndrome, when you have, say, depression, it tends to worsen those symptoms. So psychological support, counseling helps in treatment of these patients. In plantar fasciitis, is there nerve entrapment? That's a good question. Generally, no. Generally, in plantar fasciitis, there's no nerve entrapment. In plantar fasciitis, there's inflammation of the plantar fascia in the heel. And usually just localized pain in the heel. They don't have any radiculopathy or radiating pain. So, although some people maybe because some people give nerve and vitamin B complex, that may confuse one, but generally no nerve entrapment in plantar fasciitis. I also saw a question on ulnar paradox concept. Timothy, maybe Timothy, you can expound more on the ulnar paradox concept. Okay, but so I'll allow you to read more on the ulnar. That is really postgraduate question, but it yes, answer. Anyway, this is whereby the flexor digitorum profundus muscle, the ulnar nerve supplies the flexor digitorum profundus muscle, and so sometimes when that nerve is affected closer to the elbow, you may find apart from the nerve, the muscles in the hand being affected, also more proximal nerves like the flexor digitorum profundus, it also gets denervated. Any other question? So the ulnar paradox, basically look at it in terms of its whereby in an ulnar nerve injury, you get some claw hand. You get a claw hand, and it is not as severe as a complete ulnar nerve injury. So, Lavin, any other issues?
Nope. There are no issues, Doc.
Good. Thank you for attending, and keep reading.
Thank you for the class.
Okay, we'll share the signing sheet. We'll catch up with you.
Okay.
Okay, thank you.